Well, Jacqueline, it's very kind of you to invite me to present. And from the point of view of being the Director of Dementia's Platform UK, I would just say we welcome aligning with EMIF. There is absolutely no reason not to. I think there are lots of scientific and economic reasons for doing so. And so we look forward to developing that collaboration. I'm going to talk about the Roadmap project, which was a 2-year project. It finished about 8 months ago. It was looking at the potential for real-world evidence, using real-world evidence in Alzheimer's disease. I'd just like to start with acknowledging the complexity of the consortium and to commend everybody involved for the way, over a 2-year period, people really got stuck in to their different work packages, engaged and worked relatively intensively. So that was very good. Here's my favourite epidemiology slide from a colleague of mine in Oxford called Sarah Lewington. And here we have the association between usual blood pressure and heart disease risk according to age group in 5,000 people, and it's a well, it's a bit of a mess. Modern art. And then if you do the same analysis in 50,000 people, you have some sort of sense of association. Maybe there's a J-shaped curve. If you do the same analysis in 500,000 people, you get log linear relationship, and that is a definitive solution. Now, what we would like to do is to get to definitive solutions, so we don't have to be constantly repeating results, analyses, getting different results. But my point is that the data were fit for purpose. And why this is such an elegant example is the 50,000 are a random sample of the 500,000. And the 5,000 are a random sample of the 50,000. So there is no selection bias operating here. This is a really very, very nice. But bear this in mind as we go through to the rest of the presentation. Whoops. So Roadmap had a project management and various other arms, but the nuts and bolts of the program were work packages 2, 3, 4, 5, and 6. And I'm going to just present some of the evidence, some of the data that we discovered from that. If we just look at work package 2, the question here was, what are the outcomes that are important and to which stakeholders? And our answers were that if you actually go and ask them, and we're talking about individuals as the unit of analysis, really important point I want to make, individuals as the unit of analysis. Although you might have, oh crumbs, gets complicated. Okay, although you might have various different emphases, nevertheless, you can identify for which group particular outcomes are important. And that allows you to target your research, to target subsequent data collection, so that you're not assuming that the same outcomes are important for clinicians as are important for caregivers, as are important for people with dementia. And it's really critical that you have that degree of granularity in your data. So if we looked at the differences in the data gaps, we would say, okay, let's look at cohorts in relation to caregivers and families' lives, and how much data is available on these different, for cohorts, electronic health records and trials, and you'll find that the pattern of missingness, if I can use that term, is very, very different. And the point here is that data are collected for a specific purpose which is relevant to the investigator. Okay, it's relevant to the research question. And I'm building up a narrative here that we need to be moving towards purpose-driven data rather than making the best, or rather a mess, of the best data available to us. Now, there's no harm. In fact, there's every benefit in exploiting legacy data. And for example, take the EMIF study. I think that's done a fantastic job. I really do, in making the very best of legacy data. But as we move forward, there are emerging research questions which will not be addressable because the data just aren't there. So if we look at the different tools produced by EMIF AD in particular, because this was, if you like, the main informatics platform developed by and added to by Roadmap, you see there's the catalogue that PJ has alluded to. There's the transmart and the switch box for coordinating and joining up different data in a secure and manner which, if you like, respects the jurisdiction and the governance issues. And this is very, very helpful, and I do think it is important we do find ways of maintaining this. The second infrastructure we used was the Dementias Platform UK, a slightly different model where, although you have similar discovery tools, the model is that the data go into a secure environment and are never removed. They are analysed within that environment, and only reports can be removed from that for the purposes of publication and dissemination. Now, both models are helpful because some cohorts are very pleased to have their data transferred to other research sites. Other cohorts really are not. And what you'd really like is a mixed approach where you can adapt whatever governance situations apply to that particular data set so that you can access it as conveniently as possible. And usually it is inconveniently. If we look to trying to get these data and test models, we find that and this is going on to work package 4 now, so the previous one was work package 3, this is now work package 4. We found that the problem with testing disease progression models is that the data were not collected for that purpose. Okay? So if you're an epidemiologist and you're doing a study on heart disease or a study on aging, you collect data on all the different risk factors which might predict your outcome. Once you get to the outcome, it's job done. That's what you said you would do for your funders, that's what the funders accept, that's what you publish. But the corollary of that is how the disease progresses is actually not measured because you didn't intend to measure it in the first place. Now, if you've got something like heart disease, that's great. You know, you have your infarction, you either survive or you don't. It's a very discrete event. Something like aging, something like dementia, which is far more insidious, it's really not a very satisfactory design. Those chronic disease designs for aging and dementia in particular do not provide suitable data. So you're then reduced to testing very simple models, predict the MMSE, for instance, AD cases, and then you're looking at the predicted versus observed scores according to your disease progression model. Eli Lilly provided a bespoke model that they use within their organisation, where you have various other measures involved in the prediction equation. And then Novartis also produced a model, and this illustrates the willingness of pharma to engage with the project and to release what could be considered to be intellectually sensitive information. And they used the API combined cognitive score and to develop a prediction model. But here's the rub. This APCC involves 7 cognitive tests. Okay? So as the models become more complicated, so the availability of data is reduced almost exponentially because it's legacy data, you see. And there is you can be as clever as you like in trying to do this, but you're really modeling with data which were not collected for that purpose, and the repurposing is not sufficient to address the questions to the level of rigor that are required by regulators. Okay? And that is a severe limitation on encouraging collaboration between pharma, and I think a legitimate, I'm not being criticizing here, it's a legitimate constraint on collaboration between pharma and academics. Then you come to try and get hold of the data. Now this was a 2-year project, okay? A 2-year project. And when you look at all these different models, you find there are very few data sets which are actually relevant. And this is out of about 70 data sets, all right? So you look at 70 data sets in detail, you find very few relevant. But they all have different governance models. They all have different access procedures. So first of all, you identify, that takes about a year, and then you've got to get access to them. And for some that take Memento, I mean, absolutely an excellent study, but although we have access to it now, within the scope of the project, it was very hard to do. Okay, but it was just a matter of time. It wasn't a matter of willingness, it was just a matter of time getting through the So we end up with most of our analysis being done on 2 cohorts. Now, I don't think, really, that reflects well on the way that governance is done for research data across Europe. Actually, not just across Europe, across the US as well. Okay? It just says, you know, you can transfer money between banks in 5 minutes, all right? But it will frequently take you between 12 and 24 months to get a permission to access the data, whether or not you move it, all right? And it's just, if I was a politician, I'd say, this is outrageous. But as I'm British, if I'm allowed to say that here, it's unimpressive. Okay, so here we had some data on for the health economics work program, which have been actually quite productive, you know, so credit to Philippa and her colleagues. And what this data show is that the quality of life as rated by people with dementia varies, is not the same as rated by their carers. Now I illustrate this because health economists, by and large, do not use individual level data. Okay, they use sort of area data or administrative data. And it's very, very difficult with any level of confidence to go from what you might describe as ecologic data to inferences at a personal level. And what we discovered is that if you like, the framework for looking at health economic data was really underdeveloped, and that we need to have much more rigorous expectations and invite the health economists to be there at the beginning of the data collection process so they can collect the data at an individual level of measurement that would not otherwise be possible. Because if you want to price medicines, if you want to price treatment, if you want to tailor this in a precision way, then you need individual level data. Regional administrative data, it might be good for evaluating policies, but it is not good for, if you like, designing interventions. So one of the work package 6 was actually a really very pleasant surprise. I hate to say this, and I have to commend Jacqueline for this. We brought together a broad range of stakeholders, to consider the breadth and depth and the complexity of the data. Now, this was a very formal arrangement. This wasn't, let's have a cup of coffee and be cozy over dinner or something like that. This is a very formal arrangement, but it was a very constructive arrangement, and all the stakeholders appreciated being engaged in it. I think the regulators really appreciated being there at the beginning of a discussion, and they really appreciated their views being valued in terms of determining what the priorities were, where we could go, what we couldn't do, what we could do. And I think the pharma, although my industry colleagues will have to speak for themselves, I think the pharma people also appreciated having a sense of where the regulators were supportive and where they weren't. And it wasn't a sense of bias. It was much more a sense of we're not convinced by these data. Therefore, why should we change our mind? And then the academics, well, they were quite happy just to get as much information as they could from every stakeholder that was available so they could guide their next research proposal. So it really did work well, and I commend this as a model because you're talking about people working in concert in order to achieve a common goal of getting a treatment through to the public. And I just think it's really well worthwhile. One of the data discovery tools, which I think is really interesting that Roadmap developed, and this was, I think, largely due to Carlos and Synapse pushing for this. Effectively, it's the data cube, where we're looking at, we have an interactive tool which allows you to identify data sources according to their informativeness for Alzheimer's disease stages and according to their informativeness for different Alzheimer's disease outcomes. And so it includes clinical trials, EHRs, and cohorts. So for the outcomes, we had 148 AD outcomes, informed by work package 2 from the survey we did with the clinicians, people with dementia, their carers, and the academics. So we did all this consultation to identify priority outcomes. In terms of, I think the stages were fairly easy to define. It's just very standard disease stages. And what you can do is go in and, from the data cube, sort, put in your query criteria to identify particular data sets. And it really is rather neat. And you can do that. You can subgroup according to people with dementia, the views and the relative information for carers and for health professionals. Whoops. Okay, so I would commend this tool to you. I suggest you go to this website. So the Cube is hosted by the Alzheimer's organization, and just play with it. Just have some fun. Just see what it gives you. To close, I think the basic message of this talk is that if we take aging research and dementia research seriously, this is not just a matter of using legacy data. Can you think of any large population cohort which is designed to look at dementia? I just want one. Okay, let's make it easier. Can you think of any large population cohort which is designed to look at aging? I just want one. Sorry? Is it designed to look at aging?
It's not designed. It's an outcome of the way it's been designed.
So as a steering group member for UK Biobank, I can speak with some authority on this. UK Biobank is designed to have as broad an application as possible. So the airtime for specifically aging-related variables is very limited. So if you want to ask a very specific granular question on aging or dementia from UK Biobank, you'll find it hard. And that's probably the most detailed study in existence. Okay. So do we accept this? Do the health economists, do the disease modelers, do the epidemiologists, do the carers accept that, oh, it's fine, let's just live with that legacy data. We'll just make the most of it. We'll have very, very complicated, sophisticated statistical models which have so many caveats that actually nobody's going to base policy on them whatsoever. Or do we bite the bullet and say, come on, folks, the time is right to collect data which are really, really informative, dedicated to look at specific questions in aging and dementia. Thank you.